Good afternoon, everyone. It's a real pleasure to be here. We're going to be having a very interesting discussion with our panelists today about the intersection of liquid biopsy approaches and focused ultrasound. And we have extraordinary lineup of guests today. Would like to welcome our panelists to introduce themselves, and we'll get started with some questions.
Who should go first?
Please.
Okay. Well, thank you. My name is Houtan Noushmehr. I'm an associate scientist at Henry Ford Health System here in Detroit, Michigan. And I've been working with liquid biopsy for a few years and applying epigenetics as a way to detect and monitor gliomas in the liquid biopsy field.
Wonderful, wonderful. Dr. Meng, would you like to go next?
Sure. Hi, my name is Ying. I'm a resident in neurosurgery, and I work with Dr. Lipsman at Sunnybrook Hospital, and we will conduct clinical trials with the opening in neuro-oncology as well as other neurodegenerative disorders. So we're very keen and interested in incorporating liquid biopsy into our current studies and ongoing efforts.
Great. Dr. Chen?
Hello, everyone. It's such a pleasure to be together with my panelists here, and I'm looking forward to a very interesting discussion today. So I'm assistant professor at Washington University in St. Louis. All my research is all on the preclinical side, working on developing new technology or advanced technology in the focused ultrasound domain. And then our group started working on using focused ultrasound to enable blood-based liquid biopsy a few years ago. And then I'm looking forward to talk more today.
Thank you all so much. I think this is such a very topical subject, and I think it's going to generate a lot of interest. In terms of the intersection between liquid biopsy and focused ultrasound, certainly a number of outstanding questions that remain. One of those, I think, is related to what should the analyte be, or what analytes really are the ones that are closest to clinical translation? Are we thinking it's released cells after focused ultrasound treatment? Are we thinking it's DNA-based applications? And within DNA, are we thinking methylation, mutational-based? Is it exosomal? Is it a combination of everything? And would love to get the group's thoughts on that. I think the literature is just being swarmed with data from all these different perspectives, and trying to identify the key analytes might be quite useful for our audience. Houtan, would you like to start us off here?
Sure. I think the biggest challenge with trying to determine the type of analytes that you want to try to capture is really the protocols. And I think there's a variety of different protocols out there that are very specific for example, looking at the proteomics or looking at just the exomes or exosome vesicles. Okay, and sorry, I got some background noise there. I want to make sure that I'm okay. I think there's a variety of different challenges there in terms of looking at those different analytes. As I mentioned, just the methods itself is a big challenge. And so trying to kind of combine them together into one form to really detect and monitor gliomas, I think, is a big challenge. My group is focused on looking at epigenetics, and we can simply just extract out from serum or plasma, we can just get cell-free DNA. So our interest would be on cell-free DNA. It seems like it's using epigenetics seems to be a very specific protocol, allows us to really hone in on the specificity of the tumor itself and the gliomas. And so I think that is an approach that is useful in terms of both the clinical application, but also in the biology part of it, because we're looking at potential biomarkers that are relevant in terms of the biology of the tumor itself. And maybe if we were to integrate that with, say, the proteomics, that would be ideal, or even the transcriptomics. That can give us some really good insights into what is it that's really being released from the tumor itself, and then we can understand really the biology, potentially, if we had the matching tumor sample. So I think it's a combination of factors that makes this a bit challenging, but I'm happy to continue listening to what others have to say about that.
Ying?
Yeah, I would agree. So we have been very interested in epigenetics information as well. I think it has a great potential to give us lots of information. But our approach so far, just because of how kind of preliminary this field is in combination with focused ultrasound, has been to try to collect as much of the components, the blood products, as possible, and store that, and working with collaborators to generate different protocols that might be able to pick up different types of analytes. I think one of the questions that was raised was what timing would be optimal for each type of analytes you're looking at. And I think that's very analyte dependent, but our approach has so far been to try to collect blood as quickly as possible after BB opening, so that just given how long our treatments are, it does take a while. And then when we collect, we assume that a lot of the analytes are kind of decreasing by the time we collect them. So.
Hong?
Yeah, so I think so that in the past almost 2 decades, lots of research has already been done to look at what type of drugs or agents that we can deliver from blood to the brain. So based on literature, we can deliver agents with viral sizes from blood to the brain. But so far, we only have very limited research in terms of what analytes can be released from brain to the blood. So I think based on what we already know in terms of the drug that we can deliver from blood to the brain, we've already know the BB opening has a size limit, and also that size limit depends on the ultrasound parameters, for example, pressure. So I would expect in terms of what type of biomarkers, DNA, RNA, or even extracellular vesicles that we can release from brain to the blood, there's going to be size dependency, and also it's going to be ultrasound pressure or parameter dependent. So definitely there's lots research we need to do to figure out what is the optimal biomarker that we can release with this technique, and also what is the optimal parameter.
Absolutely wonderful remarks by the panel. One of the big questions is what indication clinically should we go after? Should we be thinking about disease monitoring or diagnosis or other applications? Did the panelists have a sense for what indication we think is closest to clinical application using this technology? And we'll go through the same order.
I think that's a great question. I think one of the major challenges that we have in the clinic, I'm not a clinician, so I've got to rely on our clinical colleagues, but I think one of the major challenges is looking at pseudoprogression, right? I think during monitoring, these are some of the challenges. I think about 5-10% of cases that exhibit some form of pseudoprogression as a result of treatment. And so that can be a big hindrance. And I think liquid biopsy in this area can really provide a really interesting opportunity to maybe complement images, for these challenging cases, and gives us an opportunity to potentially resolve some of these interesting situations. We're looking at that in our group, where we're trying to collect samples at time of MRIs. So we're collecting blood and we're collecting serum and plasma, so that this way we can try to see whether we can assess the efficient liquid biopsy as the tumor is progressing off treatment. So I would say that that's one of the most interesting clinical translational use for liquid biopsy, to really not only detect it at initial surgery, but to monitor during surveillance this form of approach in clinical settings.
Great. Ying, please.
I think both diagnosis and monitoring would be a very promising aspect that focused ultrasound can be applied to. I think in particular, focused ultrasound has the potential of being able to more selectively target different areas of the tumor that where, theoretically it's releasing the biomarkers from just the area it's been targeted, and you can sample that specific area. But that's something that is, I think, really unique to focused ultrasound. It's unfortunately very difficult to test that in the clinical trials right now. So would kind of loop back to our preclinical colleagues to try to test the feasibility of that idea.
Oh, please.
Yeah, I definitely agree. So either initial diagnosis, treatment monitoring, or for the pseudo progression detection. I just want to add that I think another great opportunity is to combine drug delivery with diagnosis to achieve this goal of theranostics. So if a patient coming, we know the patient carries specific mutation, then the patient can go through targeted therapy, and then we can use this technique to monitor whether the patient is responding to the drugs in a non-invasive way. And I definitely think that's also an area that is very interesting.
Absolutely. And just to launch off that, the comments from Ying and Hong, in terms of sort of data that we would need to try to bring this closer to the clinics, I think there are a lot of variables that one can think about in terms of analysis we discussed, the clinical indication, but from a practical standpoint, I think one of the unanswered questions still remains from a technical aspect. What is the optimal area, the optimal sort of parameters with the ultrasound to be able to acquire the desired analyte? And of course, on the back end, when do we collect the appropriate plasma, blood, serum samples that we're interested in vis-a-vis the focused ultrasound treatment? And so, what sort of data would you all like to see, or experiments or studies would help us try to elucidate that sequence of events from a logistical sense to be able to bring this to our patients in the near term?
I think practically, I think a lot of those questions could be probably more efficiently worked out in preclinical animal studies, just because the current clinical trials have primary endpoints that we have to meet, and these are more exploratory measures that are collected when the patients are tolerating it and able to provide samples. So, and the primary, secondary endpoints, we're already asking them to do a lot for the study. So I think, if we can work more closely with animal studies, and that can better optimize the conditions, we can certainly improve our protocols for clinical trials.
Absolutely. There's a question from the audience that relates to the prior discussion, and that's regarding trying to differentiate progression from pseudoprogression. And the question is, if we think the majority of the cell-free DNA that we're capturing is from non-tumor sources, how do we think that using focused ultrasound can help us answer the question of whether what we're seeing on an MRI scan is actually tumor cells growing versus treatment-related changes? Dr. Noushmehr, I know you said this is an area that you think is quite promising. Would love to get your thoughts on that question.
Wow, that's a difficult question. Again, it's the big challenge with this is, with the focused ultrasound, is trying to assess this during monitoring. I mean, if we want to try to get this into, I'm thinking real-time monitoring, where, a simple blood prick, just like we do with glucose and diabetes, that is really the ultimate goal, I think, with liquid biopsy, is really to have this maybe even as a home kit, right? So people can do a prick and then monitor their own sense of progression in the tumor. And again, this comes into also going back to the pseudoprogression and trying to figure out the heterogeneity of the tumors. If we're able to pick up non-tumor cells, I think that's fine as well. I mean, as long as the signal is robust and is specific to gliomas. Of course, you need trials and you need experimental validation. But as long as it's specific, even if it's a non-tumor cell-free DNA, it could be, the blood, it could be the immune system, it could be whatever that is excreted into the circulating system. I think those kind of features are still valid, and I think it's still important to explore in the context of monitoring gliomas. And if that's what's being released during pseudoprogression as a response to treatment, so be it. As long as we're able to pick it up and detect it, I think that's the critical thing.
I think it's well said. I think that part of the challenge here is to have a repository of samples to be able to answer some of these wonderful questions. And certainly, clinical trials are a great avenue, given that patients are very closely followed. They're often in a very well sort of organized selection criteria that can be a more homogeneous population to be able to derive answers from. And so, one of the questions that I've sort of struggled with is how do we get clinical trials to enable this liquid biopsy arena in a prospective fashion, especially when the technologies are so rapidly changing. The requirements for sample collection and processing are also in flux. And so, if one is interested in sort of organizing trials, which many of our audience members are, can we give them guidance on, are there appropriate time points, appropriate types of material that should be collected on a routine basis? And I'll see if Dr. Chen has any thoughts about this.
I actually think Dr. Meng is probably a better person to address this clinical trial design question. But in terms of sample collection and then how to design the trial, I just want to highlight that. So it's already known blood-based liquid biopsy can be used for brain tumor diagnosis and monitoring. So one unique feature about the Focused Ultrasound enabled liquid biopsy is the advantage to achieve spatially targeted and temporally controlled biopsy. Means with Focused Ultrasound, we can pinpoint exactly where we want to diagnose the biomarker. So this can be useful for pseudo-progression diagnosis. And another feature is the temporal control. So we can control when to collect the blood. So we know we deliver the ultrasound, we control when to collect the blood. So there's correlation between the ultrasound treatment procedure and the blood collection that give us more insight in terms of whether the biomarker we detect is from tumor or not. And then I want Dr. Meng to comment on how to design the clinical trial so that we can benefit our patients.
Thank you.
So just speaking from experience, I think to set up this pipeline, you need a really good technician who's very experienced in and very flexible in terms of collecting blood and being able to process it in a timely fashion and having all the protocol carried out exactly as is written. And having someone experienced in that regard is really helpful for our lab. So, and also working with your colleagues, the people who are going to be measuring the analytes of your choice and kind of developing a protocol that's optimal in terms of storage of the samples is really important. Even the type of tube that they're stored in is really important in terms of what marker you're going to measure. So all those things need to be taken into consideration. I think in the future, if we were to just have more studies that are done upfront to before surgery, having the patient agree to having their samples collected for these, corresponding measurements with their blood samples would be really important as well. So writing a protocol is more open to the patients accepting these kind of conditions would be important.
Very, very well stated, Dr. Meng. Really want to take a moment to thank the panelists. Really a very insightful discussion today. Appreciate the audience input, and we'll begin the next session momentarily. There'll be a short break between our session and the next, and really appreciate our panelists taking the time today to spend with us. And thank you so much for the opportunity.